to the New York State Care Management Training Initiative, webinar number 3. The subject is Navigating Complex Systems. I am Adele Gorges, Executive Director of the New York Care Coordination Program. It's my pleasure to welcome you today. A few housekeeping events. Questions may be submitted using the on-screen question box. All questions will be answered in an email that will go out after the webinar to everybody who's a registered participant. If you're joining the webinar as a group, please complete the post-event survey, which will appear in a new window immediately after the webinar itself ends. This survey will be your opportunity to provide the names and email addresses of individuals who may be watching the webinar with you, but they were not individually logged in themselves. This will assure that each of those individuals receives credit for attending and will have access to all the materials and will actually get the Q&A email for this particular webinar. Let's move on to introducing our presenter today, Peter Baumann. Peter is currently a Senior Project Manager for Finger Lakes Performing Provider Systems, one of the new DSRIP initiative. Prior to that, Peter was a Manager of Population Health with MVP Healthcare, where he provided oversight of condition health management, social work, and Medicaid managed care programs. He was an active member of the implementation team that addressed the New York State Medicaid Redesign and quality initiatives. Prior to that, Peter was part of a 2-year managed care demonstration program in the central and western part of New York State, actually undertaken by the New York Care Coordination Program together with Beacon Health Strategies. Its purpose was to develop a new model for care coordination between behavioral health and medical providers. It was a multi-county initiative where best practices for care coordination were shared with providers, county mental health departments, and the managed care plans. Prior to his experience in the managed care arena, he had 10 years of experience as a therapist for community mental health centers and managed a private practice for 4 years. He received his project management certification in 2010 and is certified Green Belt Lean Six Sigma. So, Peter, welcome to you. We look forward to an interesting day or morning. And now I turn the screen over to Peter.
Thanks, Dale. I appreciate it. Thanks for everybody taking time out of their day. For the next hour or so, we can start to look at some of the new and exciting stuff that's going on quite a bit. So just looking at the objectives, we're going to go over the changing landscape in managed care, and I think I should have put a slash in there and said healthcare, because there's a lot of changes across the board, and you'll see some similarities. We'll look at collaborating with managed care providers, how you can do that in an effective way. And we're also going to talk about how we can help individuals develop relationships with their primary care physician and healthcare providers. So, pretty aggressive agenda, but we'll do the best we can. And certainly, there's quite a bit of information to cover. So one of the things that I wanted to talk about, before we get into sort of all the multiple changes going on in the healthcare field, your role as a care coordinator, I think one of the things that we can never forget, so I've been doing this for 20-plus years, and I think one of the things that we tend to always keep in the forefront is how can we make this valuable to the individual? And so before we come up with wonderful interventions, before we come up with a great way to interact with the MCOs, we always have to remember that individuals have a choice. They can choose to work with us, to not work with us. They need to be in charge and make the decision. Again, you can be a skilled clinician, the best care coordinator on the team, but we cannot forget the individual makes the decision in their healthcare needs, and we have to figure out what makes sense to them. Another key piece is cultural competency, and I think what's important here is that these could be trainings in and of themselves. And I know that a lot of folks have taken motivational interviewing, person-centered planning, and we just need to make sure that whatever we do or approach that we take that into consideration. It's understanding the individual's perception of their situation. We might think that things look horrible for them. They just need to take the right medication. They just need to follow up. But you know what? We need to help them to get there, to make collaboration, make it part of their goals. Why does it make sense for me to interact with your provider? So I think, you know, before we get into any of that, let's just remember that's important. I just had a couple of things on here. I know that there was training previously on the patient activation measure, which looks at a readiness to change document that's really well known, and I know you reviewed that. And then I did put in a slide, and I know there were some attachments that went out to the invitees about looking at some questioning or interventions related to motivational interviewing. So just some things to consider. So let's look at some changing landscape of managed care. The good news is that by the end of this presentation, it might all change. So, you know, I could be a subject matter expert for this hour, but then it might change between now and then. I liken it kind of to the weather in the Rochester region. One day the kids were in the pool, and the next day on Sunday we're around a fire eating s'mores. So the magnitude and the extremism of the change in the healthcare system is pretty interesting. So hopefully we can touch some of the surface on that. Okay, so one thing I want you guys to think about is what comes to mind when you think of the phrase managed care. Is it sunny skies and beautiful thoughts come to your head when you think of HMOs? Typically that's not the case. Typically this comes to mind for a lot of people, not everyone. So the image as it's portrayed here is, do you have the provider, and then you have the individual receiving the service, and who's getting in the way? Those pesky managed care folks. As this page displays. But I can tell you right now, it's changing. And the MCOs who are ahead of the game understand that. And they understand that it's not about sort of containing costs. So that's sort of the old model. It's really about access. People say a lot about triple aim. So it's quality, access, and sure, cost is in there, but it's really all of those intertwined. And what you'll see through the presentation is what's really driving change now on the national and certainly on the state level. New York State is ahead of the game here on some of these initiatives related to quality, and one of the things related to quality is breaking down silos. So we'll talk a little bit about that. So the other thing influencing care. So think of the 80s, 90s, early 2000s. How did you get your health care? Well, you got your health care by these, the MCOs, managed care organizations, would go out to your employer and they'd say, you know what, we have all these great plans, employer, you go choose. You let us know what you want to give to your employees. And so sort of that's the old frame, and what that is moving to now is a customer-based. Think of Amazon.com. They're going to individual markets. That is where everything is headed towards. And as you can see on the bottom of this slide, I wanted to point out that what's happening is you're having people fall into buckets on a continuum. So based on their circumstance, they could be in Medicaid, exchanges, and sometimes Medicare. So think of it as a continuum of care. And people move from one bucket to another. So why do people stay with one MCO as opposed to another? And this is true for the Medicaid space as well. Consumers are savvy. I think that sometimes what happens is we try to put the Medicaid population, we have this image of them, which I think is rapidly changing. Medicaid, any individual is now being savvy about their insurance options. And somebody who treats me kindly, has a great network, meaning providers that are in their system, and looks at my quality of care and cares about what I do, those are the ones that are going to survive. So that is pushing managed care companies to not only focus on wellness, but to look at customer service, quality of care. When they call a provider, think Amazon. Why does Amazon survive? Amazon survives because they change pretty quick, they market to the consumer, and they take care of issues pretty quickly. I mean, I think of my son, he had trouble with his Kindle Fire. We had a new Kindle Fire in our mailbox 3 days later. And so there really is this different market going on in managed care from an employer-based to an individual-based. And that's important, as you'll see later on. Okay. So let's look at some other things impacting the system delivery. Okay, so these are just some buzzwords out there. ACOs, accountable care organizations. NCQA is a national accrediting body for providers, managed care companies that set certain standards on a national level. Patient-centered medical homes. HEDIS is a quality initiative, national standards that we'll talk a little bit later in the presentation, okay? And you'll see how they all tie. And in New York State, what's the big thing? If you haven't heard of Medicaid Redesign, you certainly are not paying attention, because Medicaid Redesign is alive and well and fast moving. And one of the biggest things that you'll hear in a lot of the presentations from the state, from health homes and beyond, the DSRIP, what they'll say is care management for all. What does that mean? What they're speaking to is the fragmented system that is currently in our healthcare space. So the reason why managed care companies are paying attention, and providers and care coordinators like yourself, is if we don't all work together and play nice in the healthcare arena, it's really going to be to our detriment. So as you'll see, you know, the silos and the fragmentation of care is really what Medicaid Redesign is addressing. Okay, other initiatives driving change is obviously health homes, DSRIP, which is DSRIP goal. The overreaching goal is reducing Medicaid admissions by 25% over a 5-year period. A lot of projects tied to that. HARP, and again, what are all these initiatives going to? They're going to value-based versus volume. The old model of care, fee-for-service. I come in, I provide a service, I get paid. That is being looked at as a different model moving forward, as a value-based payment, and we'll talk a little bit about what that means. But one of the initiatives that we're going to talk about here a little bit more that Adele's going to expand on is HARP and how that impacts the overall system delivery. So I'll hand it over to Adele.
Thank you, Peter. HARP. If you're looking for one of the changes to the insurance market, and one of the initiatives driving change in the system as we know it, HARP, is something that you want to be paying attention to. HARP is short for Health and Recovery Plans. They're a part of the carve-in to managed care of behavioral health populations and benefits that were previously fee-for-service or not part of the Medicaid benefit. The HARP is a distinct managed care product line within the bigger organization, and it is specifically for individuals with high behavioral health needs. It's not everybody who has any type of a behavioral health need. It's for the most high need of that group of individuals. Health home care managers will play a key role with this HARP initiative, and starting with the required face-to-face assessment to establish the eligibility of an individual for the HARP program. The individual will be enrolled in a Medicaid managed care program, but then they will be assessed for their eligibility specifically for the HARP, as well as for a set of expanded services that are available only to HARP members. These are generally called home and community-based services. They're newly Medicaid payable. The assessment tool is something called the HWRI Community Mental Health Assessment - New York State version. It is a very long tool, perhaps 22 or 23 questions, which when care managers hear about this, their initial reaction is, that's not possible. The good news is that we're doing a pilot with 4 different health homes in central and western New York, where at each of those health homes, approximately 7 care managers are piloting the assessment tool to provide feedback to the state on whether it's working or not working, what could be changed and made better. The good news is that the care managers who are actually using that tool are very enthusiastic about it. They actively like it. They like the information that it provides. They like the fact that it has an electronic base to it, that at the end of the assessment provides you, the care manager, with a list of potential problem areas that ought to be addressed in a care management plan. It's just very exciting to find that some of the work is done for you in the background. So, and the number of questions is not as long as it seems to be. A lot of them are information that you already know about an individual with whom you are working. So what started out as a little bit of fear and trepidation about the tool has turned into enthusiasm for it. And by the end of the pilot period, we should have a lot of feedback about how best to use it, how best to use the software. Also, there will be input from the New York City region where this tool will go live in July of this year. For the area for this training initiative upstate, it's going to be into the spring of 2016 before you actually have to use it. But something good to know, it's coming through. Another piece of good news, this is a separately billable health home service. So while it's perhaps extra work, there is a totally distinct and additional payment to the health home for a care manager doing this assessment. So care managers will start being involved in HARP at the very beginning with the assessment. That assessment will not only establish the individual's eligibility for a HARP, but also for what are called the home and community-based services. So the tool actually looks at both. These home and community-based services are an expansion of the benefit package specifically for HARP members. These are services that previously were grant-funded, deficit-funded, but not billable to Medicaid. So these are going to become Medicaid payable services for individuals who are enrolled in HARPs. They're services that I think you may recognize. They're all services that have a great deal of evidence-based research. They work. They get good results. So as a care manager, these are services you're really going to want to look very carefully at because they will help the individuals you're serving to achieve their recovery goals. So the specific new categories are rehabilitation services, which include psychosocial rehab, community psychiatric support and treatment, and crisis intervention. Peer supports are now going to be a billable services. Habilitation, which is habilitation residential supports in community settings. Respite services, short-term crisis respite or intensive crisis respite. Non-medical transportation, that's, I'm sure in many areas transportation is a key variable in being able to help an individual achieve their recovery goals. So this hopefully will bring more resources to that. Family support and training. Employment services will be one of the home and community-based services and billable. Educational support services and supports for self-directed care. I believe self-directed care is new to New York State, and there's a lot of work going on to put together what the model will look like, and that can be a very positive addition to the services that will be available to individuals. So you want to be thinking, these won't be available in upstate until probably July of 2016, but you can start now in thinking about them. Many of these are available in your local area, but just not as a Medicaid billable service, so perhaps with a more limited supply than the demand might indicate would be needed. But with the move to Medicaid, there ought to be a better ability to match up the supply of services with the demand for those services. So the opportunity for health homes is that HARP provides expanded options for services to be included in the health home care management plan. The HARP will also provide a very good opportunity for care managers to partner with Medicaid managed care plans to achieve the recovery outcomes for HARP enrollees. It will almost be an automatic introduction for you to the Medicaid managed care plans with whom you will be working on their mainstream benefit as well as the HARP benefit. And HARP, as we just discussed, provides new resources for achievement of the individual's goals, but also the DSRIP goals. I know we talked early on about DSRIP and how that interfaces with health homes. DSRIP are a key, health homes are a key part of DSRIP's ability to meet their goals and draw down that $6 billion that's available to New York State. Health homes are named participants in many of the projects, and the HARP is going to bring all those new home and community-based services and the specialized plan for individuals with high behavioral health needs. So I'm going to turn this back to Peter.
Thanks, Adele. So again, just emphasizes the changes going on, quite a bit of them, and ties it nicely to this next slide, I think, which is the key thing that quality is being looked at as opposed to quantity. And so, you know, one of the things that, again, the driver of sort of some of this change is, this was something, it's a little bit dated, this slide, but I think one of the things that the Medicaid Redesign team was looking at is the cost per Medicaid member. And what you were seeing here is we were, as a state, paying pretty much close to the most per individual per Medicaid, Medicaid dollars going, you know, the highest amount going towards individuals, and we weren't getting, as the saying goes, the biggest bang for our buck. So we're spending a lot on sort of services for individuals, and they still were having difficulty getting the care that they need. So this brought about a lot of the change. Okay, so one of the things when we talk about, I'll speak briefly here about what's called HEDIS and HWRI, okay? And HEDIS, think national, HWRI, think New York State. So HWRI stands for, it's always a mouthful to say that, Quality Assurance Reporting Requirements, okay? And HEDIS is a national benchmark for quality standards. So the best way to think about this is HWRI. There's some HWRI measures that are HEDIS measures. And why is that important? So all this information in regards to quality and standards of care are rolled up into these measures, and this is what managed care companies are paying attention to. And when I reviewed for this presentation some of the health home information, some of the quality metrics that the state is looking for with some of the health home outcomes are related to HEDIS and HWRI. And so we can have, again, a whole training on HEDIS and a whole training on HWRI, but what I try to do is bottom line it for your role, okay? So what do these things all point to? Here are the common themes, okay? Do you need to know each specific HEDIS and HWRI measure? No. The common themes are important, and what they point to is an ongoing relationship with a medical provider. That's what all of these point to. So are they getting the right care at the right time? And in your role as a care coordinator, that you can be pivotal in that process. Okay, so some of the themes are prevention guidelines. A lot of the measures are related to there's an inpatient admission for whatever reason, medical, behavioral health, maternity, okay, and did the individual follow up with ongoing care? The biggest thing, medication compliance, and obviously chronic conditions best practice guideline. So if you're going to ask me, you know, what did you take away from this this presentation? I think one of the things that research demonstrates, what leads to readmissions quicker than anything else, it's medication reconciliation. And we'll talk about that a little bit later in the presentation. Okay, that's a little bit about HEDIS and HWRI. So again, you know, why does this matter? That's great that all this quality stuff is going on, and I appreciate all the industry being in upheaval and Medicaid redesign. Why does this matter to your role? And I think this is why it matters. The care manager, care coordinator are the ones who can fit all the pieces together, okay? They can help. One of the things that I continue to be amazed at is individuals that we interact with might have quite a few organizations outreaching to them, providers outreaching to them, managed care organizations outreaching to them. There's a lot coming at these individuals that we serve. And one of the ways that we can be helpful is to navigate that. We can understand all the pieces coming together. And I think the vision, and Adele can correct me if I'm wrong, but I think the vision of health homes really is to bring all of these pieces together, because the health home case manager can interface with each individual one and help the member digest some of the information that's coming to them.
Peter, it's Margie, and I'm wondering if you might be able to expand a little bit on your experience and best practices in terms of care managers really navigating that system. Those are a lot of pieces to bring together, and could you talk a little bit about what works with that in terms of making connections with specialists, PCPs, et cetera?
Yeah, certainly, Margie. Thanks for that. I think one of the things that I always go back to when you look at good clinical care is start where the member is. So if the member is feeling frustrated with all these folks interacting with them, what immediately might happen, and what I've seen happen, is they'll tune everybody out. Look, this is a big hassle. And so I think one of the things that we want to do is help the individual prioritize what's important to them. Who do they want at the table? There might be a whole bunch of folks who want to get into the mix, but it's really up to them to empower them to say, you know what, you want this, this, and this to happen. Who do you want at the table? That's one place that I would start. The other place, and I'll talk a little bit more about that, Margie, in the presentation is that who do they feel most comfortable with? Where are they primarily getting their services? And some of the players, you know, have to decide who's in and who's out. And I think that's how we can help the individual, because they really have to understand what their plan is and what their role is. So first, have them prioritized, have them develop a plan, and then I think our role could be contacting these folks or helping to contact these folks to share the plan, so it doesn't really go against what a provider is thinking.
Great, thank you.
Thanks. Okay, so let's look at how we collaborate with MCOs. I think, you know, the managed care arena is one of the big things that the managed care companies have more than anything else is data. That's what they're great at. Managed care companies have a lot of data, a lot of information on the individuals we work with. And one of the things that we need to do as care coordinators is how can we use that data to our advantage? Because to me, you can have 100 points of data, but if it makes no value, there's no value added to the relationship of the individual I'm working with, who cares? So I think it's finding the right data and how that influences our interface with the individual we're working with, okay? So what type of data do they have? Okay, they have a lot of information on providers, okay? They determine where the individual is utilizing services and what benefits are available to them. And one of the things that I would caution folks is that what you'll see on a lot of the ID cards of individuals is they'll have an identified primary care physician. One of the first questions I would ask is, do you know who this person is? Because a lot of people would say, I have no idea who that person is. They might have been assigned to that individual. For my care, I go to a cardiologist, and it's Dr. Smith, and she's great. And that's the one where I get my primary care. And so I think the first question that you can go to a managed care organization is primarily where are they utilizing services? And it might not be the identified PCP on their ID card, okay? Because if they're going to someone, a specialist, and a lot of folks who have more complicated needs in the regulations in managed care, you can have a specialist be your primary care provider. And so I would really ask the question of the individual, where do you go if you get into trouble or you have medical issues? Because that's going to take the next step around the collaboration piece, okay? The other thing that they have is demographic issues. Now, I know it's very easy to find individuals in the community. They have the right information. I'm kidding. I understand it's very difficult to find individuals in the community, especially if folks are transient, people move, They go to different circumstances that are happening, and I think that one of the things that the MCOs could do is they have a lot of claims information. Sometimes they might have information related to maybe a couple of phone numbers, a couple of addresses that might help you with outreach, okay? They have diagnostic information, any medical problems that are going on, any high-risk situations that are going on. MCOs have that. And again, where do they utilize services? So I think it's important to know, and this speaks to me about outreach. If someone is using the ED to get their primary care needs, it might be upon us to maybe go to the ED and see if they're there and establish a relationship with those providers. Now, I know that's difficult, but if someone is primarily getting their services there, maybe it's, and I think that part of what some of the initiatives in New York State are doing is, if they're getting their care there, how can we link them to a health home care manager in the community? How can we do that? They're coming here 4 times a month, 5 times a month, you name it. We need to figure out how we can get them to the individuals, the care coordinators in the community. And I think that's going to be an ongoing discussion. There's a lot of ways to kind of get at this, and maybe in the smaller communities, if you have a smaller hospital, it might be good to have a conversation with them. But I know a lot of folks are doing this already, so something to think about. Also with MCOs, these are some questions that I thought were really helpful to think about in regards to interfacing with the MCOs is, whoever your lead health home is, how are they interacting with the managed care organizations? Because people, like any organization or individual, might be at different steps along the way. Some might have a lot of interface with the MCOs, maybe data sharing is going on, maybe not. But I know one of the things that is in, I don't know if it's regulatory at this point, but I know one of the things that the state is encouraging the MCOs to do is to share with anybody who's enrolled in a health home. If an inpatient admission occurs, we should be sharing, meaning the managed care organizations, should be sharing that information with the health homes. Now, again, people might be at different steps in that process, but it's one of the questions that we should be asking of the lead health homes and how we can be helpful in that process. Because if someone's admitted to a hospital, that would be great information to have. And if there is opportunities, or I see an opportunity for the health home care coordinator, if they're not going to the hospital, at least having a conversation with the discharge planner. Does the MCO have a case management program in place? A lot of the MCOs have telephonic case management. Some of them actually have home-based case management, depending on the managed care organization. And just like any other provider, it would be really helpful to know if someone is interacting with individuals that we're serving. So, do they have a case management program? Is the individual I'm working with someone telephonically? Again, back to what Margie was asking about questions, that could be helpful because, who's in and who's out, we got to help the individual navigate that. I just have visions of 9 people calling this individual when they're discharged from the hospital, and it can be kind of scary. Okay, and then the other questions to ask is to identify a contact within the managed care organizations. New York State has made it very clear to the health homes and the managed care organizations that there needs to be collaboration around individuals. So however that process works with the lead health home sort of being the voice of the downstream providers, however that's working, there should be an MCO contact for the health home. So if you have an individual that you're really concerned about, or you need information about what's going on in a particular health arena or health space, it's good to know your contacts in the MCO. We have to start interacting with individuals who have a lot of data on these folks. Okay. So I think one of the takeaways that I wanted to make sure people understood is that the managed care and the health homes, the goals really align. You are empowering the individual to take an active role in their health care. What you'll hear, or the big buzzword, easier said than done, is self-management. Because if people are managing their care in an effective way, it's going to improve their quality of life, and the focus is going to be on prevention. So that's a really important piece to keep in mind. And as you can see, all the dollars, all the funds are related to people meeting some of the quality metrics that I mentioned.
Peter, I know when you were at MVP Healthcare, you had a fairly innovative practice for working with health homes to provide the health homes with the contact information for the individuals enrolled in the health home. Could you just explain a little of that? Since you no longer, I don't think, would be giving away trade secrets.
I don't know.
It might be helpful for people to understand exactly how that works.
Yeah, well, and I think actually it's not a trade secret. I think it's actually what New York State is asking us to do. And I think that one of the things that that we did with the health homes that we had connections with is that if they were the portal that is utilized by the state will identify individuals that are enrolled in a health home or in active outreach status. So these aren't folks who are just assigned. These are folks in active outreach or enrolled. We would take those individuals and run it against individuals that we had in our internal care management programs and identify who the care manager was. But our programs mainly, one or two, mainly were telephonic. So that way that information could go to the health home if they're having trouble locating the individual, any goals that we're working on. So I think that that's in the spirit of what the state is looking for in regards to collaboration. So,
thank you.
You bet. Okay. So let's look at the third topic that I had was developing relationships with the primary care physician and healthcare providers, okay? So I thought that it would be good to look at some tools that you can work with individuals when they're interfacing with some of the medical providers, okay? Okay. So I broke it down into 3 areas, questions to ask a provider, personal health record, and communication outcomes. And I think one of the things that I would ask folks to think about is, you know, how do you, this is a good sort of self-evaluation, how do you interact with your primary care doctor? Because I think it's important when we're asking people to sort of look at change or look at ways of impacting their health, it's always good to do a sort of a self-evaluation of what you're doing. And so I try to think about, you know, when I went to my last primary care doctor visit, did I really share all that was going on? Probably not. My guess is generally we're poor historians. We tend to either gloss everything or we over-report or exaggerate. So, and that's just human nature. And so I think one of the things that you know, getting this presentation together is really what sort of things do you bring to your providers when you're going to them. And I think I actually got a couple ideas about maybe how I should be a little bit more, taking more of an active stance in my medical care. So something to think about. All right, so planning for a medical appointment. I think one of the things that we want to do with any medical provider, and again, I'm including, you know, behavioral health, medical, I'm not distinguishing. I think it's important to know these things from every angle, okay? And so these are just some of the highlights. I mean, if you just Google some of this information, when I was sort of perusing it, I mean, you should see some of these health histories. I mean, pages and pages long. And to be honest with you, it seemed a little much to me. And so I think, how can we get it to a way that people can digest it and it makes sense to them? So here are some key highlights or key themes in all of the health histories that I saw. It includes your current conditions, any medical issues going on, any past surgeries or illness that you think are helpful, your family health history. You know, a lot of times it's providers have a very short window to see you. And I think it's important that if you have even some highlights of mom had cancer, dad had diabetes, mom was completely healthy, dad was a smoker, those sort of things are important to have for any provider in working with you, just to have some sense of history. And bring all your medications with you, okay? And so one of the things I was thinking about in a lot of, you know, using technology for this medication question, because a lot of folks might actually be on, some might be on one medication, some might be on 20. And maybe the provider doesn't know the individual is on 20. There might have been an inpatient admission, they give them meds on the floor, you don't know. And so, you know, never assume, I guess, is my big thing. And this would be a good opportunity to use smartphone technology. A lot of people have smartphones, or where you can take pictures. And what I would suggest, one of the easiest ways to be helpful is line up all the medications and start taking pictures. That way they don't need a Wegmans bag to bring all the medications with them. So taking a snapshot of the medications might be the, you know, then they're not lugging it all around. Because again, what will happen is they might get medication from a specialist that the PCP doesn't know that they're on. There was an inpatient admission that occurred and new medications were ordered, the same medications. You would be surprised, or maybe you probably aren't, if you put all the medications on the table, is letting a provider see all of those just so they get a sense of that. And then ask someone to go to your appointment. Individuals, again, a family member, somebody that they trust, a peer, because I don't know about you, but whenever you get either a diagnosis or you know, something recently happened, or just a lot of information is coming at you, and I can just liken it to, again, personal history. So, you know, parents who have a cancer diagnosis, they have a lot going at them all at once. And so when me and my brother went with my dad in regards to his treatment planning, he probably heard maybe a quarter of what the doctor said. And so what we did is help to fill in the pieces, and it made a little bit more sense to him. And again, we're poor historians, okay? So, and so I think having another person there who knows us a little bit better to help guide us through the visit would be helpful. Okay, these are just other provider questions to think about. You know, again, what's your diagnosis, treatment? Well, you know, there's a lot of options for treatment, you know, I think the key thing that I want to emphasize here is that you need to ask the questions, because again, what a provider will come and what a provider is trained to do is hear information, make a diagnosis, make a plan. That's what a provider is supposed to do, and do it all within 15 minutes, okay? And so what I would encourage folks to do is to start to explore or question a little bit the options. And what does this mean to me? And why do I need this test? Instead of sort of, again, sort of the dynamic of setting up a bi-directional communication with the PCP so it's not one-sided. Okay, and these are just some resources. Again, these are, you know, you can certainly take these for what they will, but what I would encourage you to do is, again, back to the individual coming up with what makes sense to them. Maybe it's just 3 questions. Maybe it's just 2 that they really care about. So those are things that I would suggest that you might want to do when you're preparing for a visit.
Peter, are these resources that we might be able to print out and send out to all the individuals on the call? On the website and navigate it. So we're sending the PowerPoint out to them. But I'm wondering whether we could we print out a copy of each of these documents just to give people a sense of what's in it?
Well, what we can do is, Adele, is we can look at some of the highlights of those and put together a document for folks, you bet. So some of these resources, when you pull them up, they'll have 50 questions on there. And so what I tried to do is make it more salient to individuals and see what makes sense to them. But what I'm willing to do is come up with a PDF and then cite those references. You bet.
Okay, that would be great. I mean, I'm not suggesting that people shouldn't go to these references.
Sure.
But sometimes it's just nice to have something on your bulletin board that reminds you, think about this.
Makes sense.
Thanks.
Peter, I would just like to add a question around that, because you're describing, I think, some really awesome tools for people to self-manage their care. And I know that care managers are working very hard with people around that. And yet we have probably a number of clients, maybe even the majority, who aren't quite at that level yet. So do you have suggestions for best practices in terms of teaching clients these kinds of skills that don't involve the care manager having to actually go to appointments with clients?
Yeah, I mean, I think, again, great question, Margaret. I think best practice for me would be all these tools that you have is, what do they want out of the visit? If they can identify what they want out of the visit, either we're helping them write it out, helping them come up with a plan, having them, I think the biggest piece that I can be helpful in is take a sheet of paper with you, because you'll forget. I think there was one study, just to not go off on too much of a tangent, but one study looked at sort of docs in the OR. And so docs in the OR, you would think they do this all the time. So I think it was in Johns Hopkins, they did this whole study about OR docs doing surgeries. And what they found is that when there was a checklist for these docs, 20, 30 years experience, the number of errors dropped dramatically. And so these are, and I think it's just human nature that if we have a checklist, it's going to be helpful to us. So I would have the individual identify what they need. The other thing, again, with the smartphone, taking a picture of all the medications, okay, so they remember those. And I think that those would be some of the key best practices. The other thing that I would do, because I think a lot of folks get intimidated, which makes sense, it takes a lot of practice, is that I think, the value of role play cannot be underplayed. So you being the PCP or them being the PCP, might actually be a better thing for them. They feel like they're in the position of power. And actually, if they're the PCP in role play, you can maybe get a sense of what they're thinking, how the doctor approaches. So having a role play about the discussion, about the things that you have written down on the paper would be some of the best ways that I think you can get at it.
Thank you, Peter.
Yep, thanks. Okay, so I want to talk about a personal health record, okay? And again, what I'm doing here is, so we had something that suggested what you want to ask the provider, but a personal health record, I sort of drew that out because a lot of the literature suggested that folks who tend to have these are more in charge of their care and can navigate, okay? So let's look at some of the ideas of personal care record. I mean, why would you do it? Okay, so it's a way to track and assess your health, okay? And it's a way really to just sort of, I think of it like a GPS. So it's a map of how you're doing and where you're going. I think that's the best way to approach it. And so Those, and there's other benefits listed there. Okay? And the other thing that I think a personal health record does is it empowers the individual. And why does it empower the individual? Because it's all about self-management. It's your record, it's your health. How do you want to advocate? And the other big thing that I think it really does is it helps to prioritize the concern of the individual. So this one, you really can't see this, but I think, did we send this out? Okay, so that's something that we can, think about, but this is, and we'll send this out. The reason why I like this particular one is that it was a one-pager. I think that some of them, go on and on. I've seen some with, 5 or 10 pages long about health history, but that, to me, that's overwhelming. So, if somebody wants to go to that exhaustive, reach, they certainly can. But I think this one pager really gets at some of the key elements. Okay. And I do have some resources, and I think we can send some of those out too. So, okay. So, provider collaboration. Again, I can't emphasize enough that everybody needs to be a part of this. The MCOs, the individual we're working with, care coordinators, those are the key pieces, and fragmented care is no longer going to be, I think, on some level acceptable, because it's in working together, especially with some of the newer initiatives where the fund flow is coming from. So, okay. So what can I, as a care coordinator, communicate with the provider? I thought it was important to really look at some of these issues and how we can be helpful, because we can be very helpful to any medical provider that is working, including behavioral health provider. Again, let's not break down medical for behavioral health. And I think one of the things that we want to do is that we can share some of the results of what we're seeing with the individual we're working with, okay? So one of the biggest things that would be helpful to medical providers is changes in behavior, okay? So a medical provider sees somebody for 15 to 20 minutes. It's important for us that if we're seeing a big change, that we're having the members share that change with the medical provider, or we're informing, because if there's any dramatic swings, they need to know that. Any testing or screening that we have. Is there any depression screening, which the PHQ-9 is? Is there any therapies that we're utilizing that might be helpful for the provider to know? The other thing is, any follow-up appointments. Does the provider have any follow-up appointments that they would like the individual testing or services with a specialist? And then, like I said, one of the takeaways, hopefully, that you get is med reconciliation. And what I mean by that is, does the provider know all the medications that are on the table of the individual that you're working with? Okay? So I guess the key thing is, looking at a summary, is keep calm and empower people. Yeah, and apparently the train behind me agrees. We're all for that. So in summary, just some summary slides. And I guess one of the things that I want to let folks know in summary is around self-management, what tools are out there, what resources are out there, what information is out there. And I think one of the things that, did we have any questions, Cheryl, at any point? I think it would be a good time to address those.
Peter, it's Margie. One question that actually came in is people who are having difficulty finding a PCP that actually takes Medicaid insurance. I guess I wonder, is that going to change as we move into managed care? And do you have any suggestions in terms of helping people with that particular barrier?
So if I understand what you're saying is, what if their primary care doctor is not in their particular network, or is it there's a shortage of PCPs?
A shortage of PCPs.
Okay. And what I would, as far as what I'm thinking about in regards to how they're addressing some of that issue is that one of the initiatives is around ramping up patient-centered medical homes, and one of the key drivers of that is access. And I believe that certainly with most of the DSRIP initiatives, one of the big pieces is if, you know, are we looking at PCP access? So I think from a system perspective, they are looking at that and there is a concern. From a individual working with somebody one-on-one, what I would do is if you are ever having trouble with access or a PCP says, yes, we're accepting new patients and I'll be able to see them in 3 months, okay? So if that conversation occurs, which it can in reality, I think that, you know, on some level you have to prioritize, okay, is there a real urgent need happening here where we need to get them in? Do we have a justification to say, look, 3 months just seems a little bit unreasonable, okay? And if the answer to that question is yes, and you're speaking to multiple providers who cannot see them within a time frame, what I would do is that's when I would contact the MCO. You need to tell them. You need to call them. You need to call their member services and say, I'm trying to get this member into a PCP. There are certain standards that the MCOs have to get somebody in for timely care. And so I am more than willing to bet that you know, if you are persistent and working with the MCOs, that they will really try to accommodate and get you in to see somebody if there's an urgent need.
That's great. Thank you.
Yeah.
Yeah, Peter, that's a really good suggestion. And,
yeah.
and I think one that many care managers wouldn't think of as part of their toolkit.
Right.
To call the MCO.
That's right.
And ask for help from the MCO.
Yeah, and I think negotiating with the office, too, about sort of what the need is. And I think what happens is some of the other tool or recommendation I would have is sometimes going beyond the frontline staff might be a good thing. And so the frontline staff really are sort of the gatekeepers, the person who initially picks up the phone. And one of the ways that you could say is, I'm a care coordinator from such and such agency. I'm here with this individual. Can we speak to a nurse about some of our concerns? That might be another way that you can sort of get at that issue.
That's a great sentence. I think maybe we better be sure that that's in the questions and answers. Just, may we please speak to a nurse?
That's right.
We'll get you past the front door, which is saying, no, book, no time for anybody.
Yeah. And I think that's important to realize because, you know, providers are maxed out. And so, you know, any way that we could be helpful to them and providing more information to them is helpful. And then if you're really getting nowhere, I think the MCO is the next way to push it. Because I think one of the things, just to let you know around provider access about the state standards, is that one of the things that the state does, and again, this is not any sort of trade secret, is what they will do is to measure accesses, they will be, an individual would call and say, I want to get to a PCP, when can you get me in there? And what the MCO is supposed to do is to facilitate that on some level within a certain time frame. That's how they measure that access. So that's important.
So it is in the self-interest of the MCO for that individual to actually be seen.
Yeah.
I think that's valuable information for people to have.
And that's all, I mean, that's all on the Department of Health website, managed care, sort of quality standards. It's all very important to realize, so.
Okay. Coming down the line, the MCOs will actually be approving the health home service plans. So I'm thinking that may, again, facilitate a closer relationship between the MCOs and the health homes, and that should help the care managers get their clients into PCPs on a timely basis.
Right. Yeah, I mean, I agree, and I think that one of the things that, again, the access to the quality of care within us, and one of the bigger measures on top of, let's say, somebody had an inpatient admission, there are big quality standards, HWRI standards, HEDIS standards. Did they get timely care after the inpatient admission? There is a time frame set up, certainly in the behavioral health realm, of a 7-day follow-up. So we are, you know, the managed care organizations are measured on whether or not someone got into a behavioral health provider within 7 days.
It sounds like it might be helpful to the care managers to have maybe a brief cheat sheet of what are the requirements for the managed care plan in terms of timely access. The examples you've just given us. It might be something that a care manager would want to have on their bulletin board to be reminded that that managed care company should be their, can be, and wants to be their ally in getting that person in a timely way. And so it's not an imposition on the managed care plan. It's a help to them to call them and say, this person can't get in, you know, can you help us?
Yes, and I think that's a great point. The ally piece is what I would suggest is a really great point, because, you know, the managed care companies want to know if folks are struggling to get into care, because it does affect their overall process and their quality scores.
So we'll be happy to help them in that way.
That's right, and I'm sure they'd be happy to have you. So
sounds great.
Okay. So I'm looking at a couple of the questions here. Okay, so one was, looking at care managers in the past, many were nurses. Moving forward, we will see the assessment care managers in behavioral health having a nursing background in psychiatry. So the question is, will we have other individuals? We will see, I'm trying to look at, will we see assessment care managers in behavioral health having a nursing background in psychiatry?
Peter, I think that question came in earlier when Adele was talking about the assessment for HARPs and that being a role for care managers. And I think that's when that question came in terms of, you know, right now the care management staff I think is pretty varied in terms of experience, and some teams have hired nurses or clinical social workers. Probably wondering whether Adele or Stephen, Peter, see any need for having more clinical staff on the care management team, health home care management team.
It's my understanding that there are requirements for the individuals who actually use the HWRI tool. Offhand, I don't know what those requirements are, but they are, it's probably a higher level than some of our care managers are currently. So whether they would all be nurses, no, I don't think there would be any requirement that they be nurses, but we are certainly seeing a lot of health homes putting together teams for care management as opposed to having a single person. They're looking at teams that might have an RN and then maybe 10 care managers and 5 peer support workers. So there is some variety in terms of the expertise, and an individual can benefit from the expertise of a number of different perspectives.
Yep. And I think that might be similar, Adele, to what some teams have done in terms of hiring or using an outreach specialist. So somebody who is really skilled in one particular area doing one function.
Yes, we've seen quite a bit of that, and I think the care management agencies that have put together an outreach team are very happy with the results of doing that. I think, you know, at some point, a couple of years ago, we saw a study out of, it was Oregon or Washington State, where they had broken it into an outreach team versus an ongoing care management team. And they found the personalities of those two different individuals. They were quite distinct personalities, and they did not find that the handover from the outreach worker to the ongoing care manager was difficult, as long as it was a warm handover.
Great. Thank you.
I think one of the other things that maybe we should touch upon, Adele, is in regards to some of the, what I'm primarily involved with the DISRIP initiative and the roles with the health home care coordinator. That's okay?
Yes, very important.
And so I think one of the things about DISRIP for those, and I apologize if I'm repeating for folks who know about DISRIP, it is pretty new, but it's you know, a delivery system reform agenda. And one of the key pieces, or a lot of the projects, what you'll see is, where does the health home care manager come in? And I think that one of the big places where the state is asking us to look at that, because every community will be different, so that's what the New York State would say, here's our lofty goals, but you, community, have to come to a place where you think it makes sense for your hospitals and your partnerships. And so one of the projects that I'm involved with, there's a couple. So our particular area in the Finger Lakes chose 11 projects. One of those projects is called Care Transitions, which is the, if someone goes to an inpatient medical facility, okay, how do we get them connected in a way that makes sense? And what the data suggests, and again, this isn't just sort of my opinion, I guess I want to preface that, is that we have trouble with some of the fragmentation of care. So, and people are at different levels, different systems are at different levels. And so where I think the health home care manager has to be at the table, and again, this would be a question to bring back to sort of, you know, who is in our DISRIP initiatives, is how do we interface with the hospitals with a medical admission? We should be asking that question. So if somebody is, if there is a discharge planning team at the hospital, if there is care coordinators, because I know a lot of hospitals, again, it depends on the system, actually have care coordinators or titles of case managers on the floor. How do we get to a place where we, as part of the workflow, understand all the players that are interacting with the individuals? So I think the discussion that is going on across the state, it's not a new discussion, is how can we know that a health home care manager is involved, and then what do we do? So is it good enough just to make a phone call? Is it good enough to say that they're here? Is it good enough, should we be sending three things to them, their diagnosis? So I think, you know, those are discussions that are really important, and I do believe the state, to what you said earlier, really wants the health home care manager to be involved, because we can sort of get to a place on some level where we help reduce 30-day readmissions, but that's one piece to the puzzle. The longer piece, or the longer term goal, is that they get into the hospital and there is a handoff that occurs. And we, as health home care coordinators need to be in that discussion and having that discussions with our providers. So,
yes, I think health homes are a very important piece of the whole DSRIP initiative. And with any luck, the DSRIP initiative will strengthen the health homes. The DSRIP is supposed to be putting together an integrated delivery system.
Mm-hmm.
Well, that is one of the things that health homes are also supposed to be working on and trying to be sure that there is an integrated team. Having the DSRIP bringing its heft to that same endeavor of having integrated teams should make life easier for the health home care manager because it will be a more integrated group of treatment providers. The other thing I think that it's important for everybody to understand is that each performing provider system, which is the name of the DSRIP entity in any given location, was given the option of adding an 11th project specifically targeting engagement of individuals who were not well engaged with the medical system. It is a requirement if your DSRIP is doing a Project 11 that they use the patient activation measure that we reviewed in the first webinar. That will be the required tool for that Project 11 to use in order to gauge the current activation level for any individual. So hopefully that helps to keep bringing things full circle within these webinars. While the PAM is a tool that your health home may wish to make available to the care management agencies, it's also a tool that will be available to care management agencies in the area where there's a DSRIP that chose to have a Project 11. So it would, and in that case, my expectation would be that there would not be a charge to the care management agency to use that particular tool, which I know some individuals have stated might be a barrier to using the PAM, is the fact that it is, you do need to pay for it. But
yeah, and I think on an individual level, so care coordinator role, what does this all mean? I think the key thing is if someone has a medical admission, and we're aware of that, which we should, if we're connected and engaged with the individual, it's similar to an MCO scenario or some of the tools that I discussed is you want to call the hospital and see who created that discharge plan, who's the care coordinator, and how did it go? Because the individual might lose the discharge plan, they might not even know what it is, but again, a lot of these systems have very good discharge plans when you look at them, and so the key thing is, can you get your hands on that to help the individual, certainly with follow-up appointments, pharmacy appointments. I mean, ideally what you'd like to do is if you find that they're in the hospital, you call then. I mean, that's what you ideally want to do, but if it's after the fact, you can get some of that information, especially around follow-up medical appointments. So.
Yeah.
Peter, we had a question come in the chat session.
Sure.
And they stated, we have a problem with some of our mental health providers kicking clients out of their facilities for missing appointments and are not allowed back in. Can this be a phone call to the MCO?
I think it could be. I don't think that that's a bad question to ask the MCO to see if they, you know, have any thoughts about what we should do about that. But again, I would look at the individual discussion with the mental health provider in that space, because there's a lot of reasons why that's occurring. And, you know, could it be, And on some level, we almost have to meet them halfway, because the scenario that I was talking about is a PCP is saying, we'll take you, but it's just going to be a ways down the road. This is a scenario where someone has multiple appointments and not showing up. And so what I would ask from an individual care coordinator level is, could there be a way of assessing why they're not going to that visit? And are they not finding it helpful? Is there a transportation barrier? Is, you know, I would sort of take it from that angle, because there's a reason why people aren't going. And if they're not getting anything out of it, well, then you need to have a conversation with that therapist about what you need that's going to incentivize them going there. So we're only going to go to providers or therapists that we think we're getting something from. So, okay. Yep.
Great. Thanks.
So I guess in summary, I guess hopefully we gave you a couple of tools here. I know we have a couple action items that I hope somebody was writing down. So,
yes.
but I know you were, so we can. It's recorded. We can go back. And so, you know, in summary, I think one of the things that I want to drive home is the self-management piece. Hopefully you got some tools today, some resources and information. And I guess one of the things that I would suggest to you is that figuring out who's involved in this individual's life is key. And the MCO can be helpful in negotiating some of those network issues. And as you can see, embedded throughout the whole presentation is the ability to access care to meet their quality metrics is you have a pivotal role in doing that. And we all have to sort of work together to kind of get to that space. So I don't know, Adele, if you have anything else to offer.
I do not. This has been a great opportunity. Thank you, Peter. Moving on, I think you've got some references.
It's showing up here. There we go. Okay. Yeah, so these references here are just sort of where, you know, just so you don't think that I'm making all this stuff up. So these are just references of what I use to get at some of the materials, some of the trends in healthcare. There's some really good resources here related to some of the plans that I showed you guys as well. So.
Okay. We thank you all very much for having been with us today. We hope this has been helpful to you. Again, a reminder, if you're joining the webinar as a group, please complete the post-event survey, which will appear in the window immediately after the webinar itself ends. This survey will be your opportunity to provide names and email addresses of individuals who were joining the webinar with you. The webinar has been recorded. It will be available on the CPI Learning Management System, which you are registered in if you are on this webinar. Some contact information for NIAPers. It's Ruth Cologne Wagner, and there is her email address. For the New York Care Coordination Program, your contact would be Diane Newville. And for the Center for Practice Improvement, Nancy Cavell, and her email address. Thank you very much. We will look forward to continuing this discussion with the Supervisor Learning Collaborative for the supervisory skills component and then the regional feedback discussions. And I particularly want to thank Margie Meath, one of our facilitators, for joining us as a part of our presentation team and looking for areas where a question might help to clarify a point that we've been making. But again, put any questions you have into the question box, or you can certainly send them to either Ruth or Diane, and we would be happy to add those to the questions and answers that we will be sending out to you. So thank you very much.
Thanks, everybody. Have a great day.
Thanks, Adele. Bye-bye.